Hello, my colleagues. I will talk today about an important topic which is a recently released new
In the
advance
last
from
few
the
years, we
ESC
have a lot of
composition papers
cardio-oncology.
in this field, but finally we have all this data gathered in a well-organized manner in a single source. So we can find an answer for this difficult scenario as we will discuss in the coming slides. The journey of the cancer patient who is candidate for a potentially cardiotoxic drug is a long journey with three main stations. The first station is the baseline risk assessment, where we assess if our patient have baseline cardiovascular disease. This will impact our decision as any patient with a baseline cardiovascular disease is a high-risk patient. So if we have a luxury to have another type of less cardiotoxic drug, this will be a perfect option. Or we might have certain measures that decrease the toxicity of this drug in such type of patient. The second issue is baseline risk factor assessment. As we all know that cancer and cardiovascular disease share a common risk factor like age, diabetes, hypertension, dyslipidemia. A well control of this factor has significant effect on the decline of incidence of potential cardiotoxicity during the therapy, as we see here. So, moving to the second stage, which is surveillance of our patient while he is taking this potentially cardiotoxic drug. Surveillance include clinical data, some investigation like ECG, echo, biomarkers like N-terminal proBNP and cardiac troponin. The frequency of this surveillance depends on the baseline risk assessment. So, for example, if we have a high risk or a very high risk patient, the surveillance will be closer in a short interval than another patient who has a low or a moderate baseline risk. The benefit of this surveillance is early detection of any cardiotoxicity cause. Early treatment of this affection has a high potential for recovery. The more we start the treatment earlier, the more the potential for recovery. And we can also start a cardioprotective drug at this stage. The third stage is which is the longest one, which is the long-term follow-up of these patients. As you might know, some cardiotoxic drug has the maximum incidence of cardiotoxicity after the patient finish the course of this drug. For example, the cardiotoxicity of the famous group of drugs, which is anthracycline family, occur in 98% at 1 year after finishing the drug, with the mean time duration of cardiotoxicity occur on about the 3 months post-therapy. And another example, the toxicity of radiotherapy occur starting 5 years after the end of radiotherapy. So that's why we see the rising curve even after the patient stopped the cardiotoxic drug. And here comes the importance of long-term surveillance. Now we start with the first station as we discussed the baseline risk assessment. This includes a brief history of the clinical risk factor, symptoms of cardiac disease or non-cardiac disease, history of any previous exposure to cardiotoxic drug and the doses and the type of these drugs, and is the patient developed before any cardiotoxicity or not. And this also includes some tools like ECG, baseline echo, and biomarkers in high-risk patient or patient with non-cardiovascular disease that include PMP, high-sensitive troponin, and this also include a metabolic profile like hemoglobin A1C, kidney function, and lipid profile. After we gather all this data, we put it in this risk assessment tool, which is HFA-ICOS, which stands for Heart Failure Association of International Cardio-oncology Society. Uh, Simply, the variables are that we just talk about, the clinical risk factors, the previous cardiovascular disease, the data gathered from ECG, from echo and biomarkers, and then we have a risk score for this patient. Grades start from low risk, medium, high, reaching a very high risk. For example, a very high risk means this patient has a potential of more than 20% to get cardiotoxicity during this surgery. And here is the importance of baseline risk assessment. Now we know that our patient is high risk or very high risk. A cardiologist with special interest in cardio-oncology should be involved in the multidisciplinary team and discussion regarding any other option rather than this cardiotoxic drug. If we left with no other option and the patient has to take this drug, then we should start a cardioprotective strategies that we will talk on the coming slide. If our patient is a low-risk patient, so he will follow up with the routine surveillance interval, as we will discuss according to each protocol. In the moderate risk patient, the surveillance become in a closer interval, and we might involve a cardiologist with interest in cardio-oncology, which take class 2B here. In the high risk and the very high risk patient, we have some steps to minimize the potential of cardiotoxicity, like minimizing the dose, like starting cardioprotective drug as ACE inhibitor or beta blocker. The most studied one is carvedilol. In some type of chemotherapy like anthracycline, if we give the liposomal form, this gives less liability for cardiotoxicity. And there is an iron chelating agent, which is a dexamethasone, which decrease the uptake of the anthracycline by cardiac cell and decrease the likelihood of cardiotoxicity, especially in doses more than 200 with doxorubicin. Statins also, we have a lot of data from multiple randomized control trial showing the protective effect of statin in high risk and very high risk patient who is candidate for a potentially cardiotoxic drug, which is class 2A as we see. The second station is surveillance during therapy. You must know what you are expecting from this drug. What is the kind of cardiotoxicity we are expecting with such a drug, so we can early detect it and we can early start management. As we see here, expect the unexpected, then you will never be surprised. The term of cardiotoxicity is a broad term, and as we see here, this term CTRCT is a novel term, stand for chemotherapy-related cardiotoxicity. As we said, it has a broad spectrum, which include heart failure, or which is called CTRCD, chemotherapy-related cardiac dysfunction, myocarditis, vascular toxicity causing coronary artery disease or peripheral vascular disease or venous disease, arterial hypertension, pulmonary hypertension, pericardial disease, arrhythmia. Each group of chemotherapy or radiotherapy has a predominant, some have a predominant cardiotoxic effect, as we will discuss in the coming slide. Starting with the famous group of drug, which is anthracycline. Anthracycline are used in many types of malignancy, like blood malignancy, lymphoma, and leukemia. So they are broadly used in children with these blood malignancies, and also in breast cancer. The famous side effect of this drug is chemotherapy-related cardiac dysfunction or heart failure. Uh, in the previous decade, all the data we have are saying that anthracycline toxicity is irreversible and dividing the cardiotoxicity into type 1 injury and type 2 injury. But this data are totally substituted with a novel data saying that more than 80% of uh, anthracycline-related cardiotoxicity are reversible as soon as they detected early and treated early, and hence the importance of periodic assessment and surveillance during the drug. As we can appreciate here, the surveillance frequency depends, as we said before, on the baseline risk of the patient. So that patient with high risk or very high risk, the frequency of sampling of cardiac biomarkers are on each cycle, before each cycle, and echo every other cycle. The frequency become wider in moderate and low risk patients. And as we can appreciate here, the surveillance does not stop at the end of drug. As we said, 98% of anthracycline-related cardiotoxicity occur 1 year after the therapy, with a median duration of 3 months. So we can see here that surveillance continues 3 months post-therapy and 1 year post-therapy. So the cardiotoxicity related to anthracycline, as we said, which is called chemotherapy-related cardiac dysfunction, are divided into two groups: symptomatic heart failure and asymptomatic heart failure. And symptomatic heart failure subdivided into grades. Very severe, that mean our patient in hemodynamic instability that need inotropic support or mechanical support. Severe symptomatic, which means the patient need heart failure hospitalization. Moderate symptomatic, which means the patient need outpatient intensification of diuretic or heart failure therapy. Mild symptom, which means the patient is mildly symptomatic with no need of intensification of his therapy. The second group is asymptomatic heart failure, which is subdivided according to the extent of myocardial affection into severe asymptomatic, where the ejection fraction drop below 40, mild asymptomatic, where the ejection fraction is more than 50, and it requires another data to prove the subtle myocardial affection, such as global longitudinal strain drop 15% from the baseline, and or rise of biomarkers like troponin or BNP. In the moderate asymptomatic group, this means either drop of ejection fraction more than 10% to a range between 40 and 49, or this might be less than 10% to a range of 40 to 49, but this should be associated with a new relative decline in the longitudinal strain more than 15% or rise of biomarker. So what we can do if we find that our patient developed chemotherapy-related cardiac dysfunction with anthracycline? This again depends on how is our patient, is he symptomatic or asymptomatic. Only in one scenario we can continue therapy, which is mild asymptomatic, or after multidisciplinary team discussion about the safety of continuation versus the potential risk from interrupting chemotherapy in mild symptomatic patients. So in mild symptomatic and asymptomatic, we have a window to continue as long as heart failure therapy in symptomatic patient and cardioprotective measure including ACE and beta blocker together with very close surveillance with cardiac biomarker and echoes global longitudinal strain during each cycle or every other cycle. In the all other scenario, we should interrupt chemotherapy, and even in very severe or severe heart failure, we should discontinue the therapy at all and not returning again to it. So, and starting heart failure, of course. So, after we interrupt the therapy, for example, in a moderate symptomatic case, and we are following our patient, and the patient recovered his ejection fraction, and the biomarkers normalize, then after multidisciplinary team approach, we might consider restarting the drug, as long as our patient didn't develop a very severe or severe form. And if we decide to resume the chemotherapy, we should follow the protective measures, including liposomal form or taking chelating agent like dexamethasone. Second agent is the human epidermal receptor antagonist, HER2 antagonist, which is used in breast cancer. The most common side effect is also chemotherapy-related cardiac dysfunction and heart failure. Again, the surveillance with biomarkers and the echo depend on the baseline risk assessment. If we have a patient with high risk or very high risk, the surveillance will be on each cycle or every 3 months, as mentioned here. This interval become wider in a low or moderate risk patient. Returning to one of our quizzes, we have a 60-year-old female receiving HER2 inhibitor therapy with a follow-up echo showing a drop of ejection fraction from 60% to 45%. Should we continue? The answer from this algorithm. In all scenarios, we should stop treatment. Only in mild, and here more than mild, moderate, asymptomatic, we might continue therapy. And also in mild symptomatic. In other scenarios, we should interrupt therapy and start heart failure treatment. In case we decided to continue treatment, like our patient which developed a moderate asymptomatic cardiac dysfunction, this patient should start heart failure treatment. And if she has mild affection, she should start cardioprotective therapy with ACE and beta blocker, with close surveillance of biomarkers and echo before each cycle. The third agent is fluoropyrimidine. This group of therapy used mainly in GIT cancers, and it has predominant vascular toxicity in coronary arteries in the form of augmented coronary spasm and endothelial dysfunction, and this might predispose to acute coronary syndrome or ischemic manifestation. And here we can appreciate that added to the regular surveillance and baseline assessment, here we stress on the metabolic profile and risk factor for coronary artery disease assessment by the SCORE2 and metabolic profile including A1C and lipid profile. We might also consider if our patient is at a high risk or a very high risk from the baseline risk assessment, a non-invasive assessment of coronary artery disease before starting therapy. So moving to the second scenario, a 70-year-old male patient with metastatic lung cancer presenting with inferior stain. What to do? Again, the most important question in this scenario is what is the prognosis of this patient and what is the bleeding risk of this patient. If we are dealing with a patient with a metastatic cancer, and the oncologist said his prognosis, life expectancy, are very short, less than 6 months. So the competing risk of dying from cancer is more likely than from ischemic heart disease. And we might do harm if we stent this patient and keep him on high antiplatelet therapy. This patient may die from bleeding rather from cancer itself or from the acute coronary syndrome. So, as we see here, a conservative non-invasive approach should be considered in patients with poor life expectancy less than 6 months or very high bleeding risk patient, even a STEMI patient, and taking class 2A recommendation. And if we decide if this patient have a life expectancy for more than 6 months, we should also consider some measure to decrease the potential of bleeding in such patient, like adopting radial approach, using intravascular imaging to minimize any stent-related complication on the long term and the need of revascularization. If we have a borderline lesion, we should do a physiological assessment with FFR, as we might defer stenting upon the result. It is also recommended to use a platform with a potential low or very short depth therapy, like the biofreedom stent. We have a data from the LEADER-3 trial, the Ultimaster stent, the data from Master Depth trial, and we have also a data on the Create stent and the Onyx stent from the Onyx 1 trial. And there is some data also from a different registry about Vine's stent on a brief depth therapy for 1 month in all these platforms. So, as we see here, a short depth strategy should be considered in cancer patients, especially with very high bleeding risk. And it is fundamental that we will stop the offending drug upon diagnosis of such complication. An important issue is these patients usually have some sort of platelet dysfunction or thrombocytopenia. So, aspirin can give till a platelet count of 10,000. Below this, we should stop. Clopidogrel to a platelet count of 30,000. Prasugrel or ticagrelol better to be avoided, as we said, we should take a rather conservative approach and minimize the potential of any bleeding. But if we opted to use this drug, we can use it if the platelet more than 50,000. Another issue in such patient is if we have a patient, for example, acute coronary syndrome and coronary angiography revealed multivessel disease. Should we do BCI for this patient or CABG? This question depends on the life expectancy of this patient. CABG might be an option if the life expectancy of this patient more than 1 year. If the life expectancy of patient less than 1 year, then BCI is preferred. Moving into another agent, which is vascular endothelial growth factor inhibitor. Most common member of this family is Avastin. It's also broad spectrum family used in many malignancies. The most common side effect is systemic hypertension. Why systemic hypertension? Because this drug affect the synthesis of nitric oxide in the vascular endothelium. So it creates some sort of endothelial dysfunction, and this aggravates hypertension in such patient. The guanylcycline synthase, that the nitric oxide synthesis is also not important for endothelium, but also for the myocardial function. So another side effect of this type of drug is cardiac dysfunction and heart failure. This drug also has a thrombotic effect and increase both venous and arterial thrombosis. A unique also side effect of this family, especially with vandetanib, is prolongation of QT interval. So during uh, uh, therapy with this family, baseline risk assessment should include echo and biomarkers. With surveillance during the therapy with this tool, the frequency depends on the baseline risk assessment as we discussed before. In high risk or very high risk, so we will do this test in a closer interval. And also, hypertension and blood pressure monitoring during therapy is essential. So, what is the management of hypertension in a cancer patient? This depends again on the patient we deal with. Is he a frail patient or a patient with poor prognosis and life expectancy less than 1 year, or we have a good profile patient with a good life expectancy? If we are dealing with a cancer survivor patient, especially if he is a high risk patient, we might start the treatment at a lower threshold than the regular 140 for systolic. So we can start at class 1 indication, we start treatment at 135 systole, and at 130, this is class 2. If we have a patient with metastatic cancer with a poor prognosis and life expectancy less than 1 year, we might start treatment at a higher threshold at 160. If the life expectancy is between 1 year and 3 years, we also might start treatment at 160, or class 2A to start at 140. And in other scenario, we start at the regular cutoff point, which is 140. What is the treatment option? If you have a patient on grade 2 hypertension with a blood pressure more than 160, this means this patient will less likely to be controlled on a single agent. So we can start a combination from the start. The best combination is dihydropyridine calcium channel blocker like amlodipine and ACE inhibitor, which has a cardioprotective effect. If the patient is on grade 1 hypertension, so a single drug might be enough. An important issue here is it is better to avoid the non-dihydropyridine calcium channel blockers like verapamil and diltiazem, because they have a lot of drug-drug interaction with some things. If we have a patient with resistant hypertension, we might include spironolactone or beta blocker, especially with the nitric oxide releasing effect like nebivolol and carbidopa. So, what is our target in this patient? The regular target, which is less than 140/90. We might go further down in patient if this is well tolerated, below 130 but above 120, and two diastole below 80 but above 70. On a more frail patient or a metastatic patient, the threshold might be slightly higher to a target between 140 and 160 for systole and between 90 and 100 for diastole. Second issue is prolonged QT. If our patient have a baseline QT interval above 480, so this patient has a very high likelihood to develop the prolonged QT and arrhythmia during therapy. So it is better from start to check any alternative drug for this patient. And if we have no alternative drug, we might consider to start a drug with close monitoring of QT. When we stop, if the QT become prolonged more than 500. Another group of drug which is the BCR-ABL drugs. This drug used mainly in chronic myeloid leukemia. This include dasatinib, which has a predominant toxicity on pulmonary T, causing pulmonary hypertension. Nilotinib and monatinib, which has a predominant vascular toxicity on the peripheral tree, because these drugs cause some sort of metabolic syndrome like lipidemia, hyperglycemia, and hypertension. Another subtype of drug used for lymphoma, which is the proton tyrosine kinase inhibitor, include ibrutinib. This group of drug causes systemic hypertension, heart failure, and AF. Importantly, this drug increases the bleeding risk. So the drug should stop 3 to 7 days before any invasive procedure and shouldn't be taken with dual antiplatelet therapy. If you notice here the surveillance of ponatinib and nilotinib, which has a predominant vascular toxicity in the peripheral bed, we notice that we have ankle brachial index on the surveillance. And we notice also we have the importance of surveillance with metabolic profile, including lipid profile and hemoglobin A1C with this drug. And the importance of surveillance with echo, specifically for the tricuspid regurgitation velocity and estimated pulmonary artery pressure, cause the high risk of this drug on developing pulmonary hypertension. Again, the frequency of surveillance depends on the risk and the baseline risk of our patient. So, what we should do if we detect pulmonary hypertension in a patient taking the dasatinib? We should stop treatment if the tricuspid regurgitation velocity more than 3.54 meter per second. We might consider halving the dose of drug at tricuspid regurgitation velocity between 2.9 and 3.4 meter per second. And in this patient who developed pulmonary hypertension, we should do right heart cath. And we might start pulmonary hypertension targeted therapy for this patient. Usually it is commonly reversible after 3 months of discontinuation of this drug. A general piece of information that all type of pulmonary hypertension might develop in cancer patients. Drug like dasatinib, which cause type 1 pulmonary hypertension. Type 2 can be noticed in patients who develop left-sided heart failure due to cardiac dysfunction. Type 3 might happen with certain drugs that cause lung fibrosis, like bleomycin. Type 4 can occur in patients who developed thromboembolism or pulmonary embolism on some group of drug. Type 5 can happen in patients who have blood malignancy, leukemia, lymphoma, etc. So all type of pulmonary hypertension can be seen in a cancer patient. Another group of drug is the proteasome inhibitor. This drug are used in treatment of multiple myeloma. A unique information here is the patient with multiple myeloma usually on about 70% of cases have cardiac amyloidosis, and hence heart failure and atrial arrhythmia and thromboembolism is higher in patients receiving treatment for multiple myeloma. Another important information is that treatment of multiple myeloma include combination of 2 or 3 families of this drug. Most commonly used one of alkylating agents, cyclophosphamide or melphalan, with immunomodulatory drug like thalidomide or lenalidomide, plus proteasome inhibitor like proteasome or carfilzomib. plus steroid. Hence, the toxicity of uh, likelihood of toxicity in such group of patients is a little bit high because the cumulative risk is high. The surveillance, as we see here again, depend on the baseline risk of the patient. Closer surveillance in high risk and very high risk patient with echo and cardiac biomarker. And if we have stigmata for cardiac amyloidosis, we should undergo further investigation with cardiac MRI or even endomyocardial biopsy according with more close monitoring of such patient. Blood pressure monitoring is also important because this group might develop hypertension. So, what if our patient develop atrial fibrillation? This cohort of patients have both increased thrombotic risk and high bleeding risk. So it should be individualized approach depending on the patient thrombotic risk, saying that VASCO score underestimates the risk of cancer patient. So we can see here that even if VASCO score is 0, anticoagulation might be considered with class 2. Another important issue, as we said, the bleeding risk of such patient. So that if we have a patient with very high bleeding risk, we might opt to no anticoagulation at all. Very high risk bleeding patient means that patient has either platelet below 25,000 or recent major bleeding, which is defined by bleeding causing more than 2 gram drop of hemoglobin or requiring more than 2 packed RBCs transfusion or in organ threatening like intracerebral or intraocular bleeding, or in a patient with brain metastasis. All this patient might opt for no anticoagulation at all, and we might consider left atrial closure device in such a group of patients as long as their life expectancy is more than 1 year. And remember that all left atrial occlusion device necessitate at least single antiplatelet for lifelong and depth for at least 1 month. So I think this group of patients with this profile will not also be fit for left atrial occlusion device. Another question is: this patient have valvular or non-valvular AF? If we have a valvular atrial fibrillation, the patient with moderate to severe mitral stenosis or mechanical prosthesis, so we left with no option rather than vitamin K antagonist. On the other group of patients, novel oral anticoagulant might be used. All the NOAC landmark trial include a cancer patient. So we can extrapolate the data from this trial on this type of patient, and we can use NOAC for atrial fibrillation in a cancer patient with class 2A. There is two scenarios where we can't use NOAC. If the patient has a platelet below 50,000, or if this patient has GIT or genitourinary tract cancer, because these are common sites of bleeding from NOAC. And of course, this patient should be maintained on proton pump inhibitor for gastric protection. So in this type of patient, we have an option of low molecular weight heparin with class 2A recommendation. We should also consider a patient-centered approach, taking patient preference in our mind, and the potentials of drug-drug interaction. Okay, what about venous thromboembolism? As we just said, that patients with multiple myeloma usually received 2 or 3 group of drugs. Each group of this drug has a potential risk for venous thromboembolism. So patient taking this combination of drug should be kept on prophylactic anticoagulation. The choice of prophylactic anticoagulation depends on the patient risk. If we have a patient who has a previous thromboembolism, DVT or pulmonary embolism, then we have only low molecular weight heparin. If our patient has another uh, risk factor, multiple risk factor, he should receive prophylactic dose of low molecular weight heparin. So again, if the patient has previous thromboembolism, he receives therapeutic dose. If we have multiple risk factor, he received prophylactic dose, and this should be continue at least during the first 6 months of therapy. Aspirin might be considered as alternative to low molecular weight heparin in a patient with no or one risk factor, rather than, of course, previous venous thromboembolism. We have also an option that take class 2B recommendation, which is low dose apixaban 2.5 twice daily or rivaroxaban 10 mg once daily as alternative to aspirin or low molecular weight heparin, but not in patient again with previous venous thromboembolism, because this patient has a very high risk of recurrent event. And here is the risk factors contain clinical risk factor and myeloma related risk factor, like the use of high doses of dexamethasone, the combination of drugs as we said before. What about if our patient developed already a thromboembolic event like DVT or pulmonary embolism? What is the anticoagulation option? Apixaban, edoxaban, or rivaroxaban are recommended for treatment of symptomatic or incidental venous thromboembolism in cancer patients without a contraindication. Contraindication, as we said before, if the patient has GIT or genitourinary tract malignancy or the platelet below 50,000. Low molecular weight heparin can be used as option with class 1A indication with a full dose if the platelet more than 50,000 or a half dose if the platelet between 25 and 50,000. Also, extended anticoagulation beyond the 6 months therapy is recommended in this patient, especially with active cancer or metastatic cancer. In patients who developed catheter-related venous thromboembolism, a minimum duration of anticoagulation for 3 months or as long as the catheter left inside. Another group of drug, which is the immune checkpoint protein inhibitor, nivolumab. This is also a broad spectrum drug used in a lot of blood malignancies. The most pathognomonic side effect of this drug is myocarditis, because the immune checkpoint job in our body is it is act as the brake of immune system. So if we inhibit this brake, so we have unopposed hyperactivity of T cell. This might cause myocarditis. Hence the importance of baseline risk assessment with echo and cardiac biomarkers, and also surveillance during therapy with a frequency depends on the risk of patient, especially with cardiac biomarkers. Here our scenario, a 20-year-old male patient receiving immune checkpoint inhibitor therapy presenting with shortness of breath. What is the next step? We just said that this drug has a pathognomonic side effect, which is myocarditis. So a patient taking it and develop heart failure symptom, we should suspect this side effect, which is myocarditis. Upon suspicion, a bolus or a pulse dose of steroid methylprednisolone 500 to 1000 should be given for a minimum of 3 days while investigation of this patient with ECG, echo, biomarkers. If our patient is stable hemodynamically, the best diagnostic approach will be cardiac MRI. If our patient is unstable, then the next step will be uh, endomyocardial biopsy. And the therapy depends on the status of the patient. If our patient is hemodynamically stable and he is responding to the steroid therapy, the response is defined by improvement of his symptoms, improvement of his ejection fraction, improvement of decline of biomarkers more than 50%. Then we can switch our patient after these 3 days of steroid into oral prednisolone 1 ml per kg per day, and then very gradual weaning protocol with surveillance with biomarkers during withdrawal of steroid till complete recovery. If our patient is steroid refractory, so a second line immunosuppressive drug like tocilizumab might be considered. If our patient has fulminant myocarditis, so beside close monitoring in ICU and optimal cardiovascular treatment, including mechanical support, we might opt to start a second line treatment beside steroid from the start, like tocilizumab, as I said before. Finally, another group of drug, chimeric antigen T-cell receptor therapy, Chimera. This also has a pathognomonic side effect, which is cytokine storm, causing myocarditis, which is mediated by interleukin 6. So again, baseline assessment with echo biomarkers is essential, and if we are suspecting such side effect myocarditis, depending on this score, which is the release from the American Society of Transplantation and Cell Therapy for diagnosis of cytokine release storm more than 2, we should do echo and biomarker for this patient and start treatment with pulse steroid. And we might consider also interleukin 6 antagonist tocilizumab antibody and treatment according to the status if the patient need mechanical support or something like that. This score has only 3 parameters: hypoxia, tachycardia, hypotension. Hypoxia and fever and hypotension. If the patient has 2 of these parameters, so he has a high score and should undergo this investigation. Then finally, with a collection of drugs with certain side effects, like rhythmic therapy used for sarcoma, melanoma. These drugs might cause heart failure, atrial fibrillation, hypertension, or prolonged QT. So monitoring during therapy with ECG, echo, and blood pressure is essential. The same with endothelial growth factor receptor inhibitor, osimertinib, used in non-small cell lung cancer. The same side effect and same surveillance. Hormonal therapy for prostate cancer, which include GnRH agonist. This drug causes a metabolic syndrome-like state, dyslipidemia, diabetes, and hypertension, increasing the incidence of ischemic heart disease and heart failure. We have another option, and if we have a patient with a high risk for coronary artery disease, is the GnRH antagonist, which is more safe in such patients. And again, surveillance with score, risk assessment, and metabolic profile with A1C and lipid profile is important in patients receiving hormonal therapy. Similarly, with hormonal therapy for breast cancer, we have the aromatase inhibitor family with the same side effect as hormonal therapy for prostate cancer, increasing the incidence of diabetes, hypertension, dyslipidemia, and hence coronary artery disease and heart failure. Surveillance with score and metabolic profile is important, and treatment with estrogen modulating therapy like tamoxifen increase the incidence of venous thromboembolism like DVT and pulmonary embolism. So it should be avoided in a patient with a high risk for venous thromboembolism at baseline. Finally, stem cell transplant patient. This unique group of patients has a very high risk to develop cardiac toxicity, because this patient usually receive a combination of chemotherapy and radiotherapy. So baseline risk assessment with echo and biomarkers and surveillance during therapy is very crucial in such group of patients, and also long-term follow-up as we will discuss. The last thing is radiotherapy. Radiotherapy toxicity is dose dependent, and unique features that this toxicity developed usually late, usually start at least 5 years after stopping radiotherapy. And essentially can affect all structures, including cardiac muscle causing restrictive cardiomyopathy, pericardium causing pericarditis or constrictive pericarditis, valvular lesion, which have a unique affection of the anterior structure, so it affects the aortic valve more than the pulmonary valve, and it affects the base of the valve rather than the commissures. It also affects the anterior mitral leaflet more than the posterior one. Might also affect coronary artery, carotid if it is in the field of radiotherapy, or renal artery if the patient receives radiotherapy on his abdomen. It has also a synergetic effect with anthracycline. Both increase the cardiotoxicity risk of the other. As we see here, the risk depends on the mean heart dose of radiation. If the heart is on the field of radiation, a dose below 5 gray is a low risk. A dose between 5 and 15 is a moderate risk. A dose above 15 is high risk, and above 25 is at a very high risk. A lower threshold is considered in patients receiving toxicity therapy more than 100. So baseline risk assessment with score risk is important with this patient because of the potential vascular toxicity, and also baseline echo assessment is considered, and long-term surveillance as we will discuss in the coming slides. Another important issue is radiotherapy not only affect the heart, but also it affect our treatment plan. So if we have a patient with a previous history of chest radiotherapy on the heart field, and he is coming for a CABG surgery, so it is essential to assess the lima and rima patency before going to CABG blindly, because this graft might be affected or degenerated by the effect of radiotherapy. And so we can consider a rather percutaneous strategy with PCI rather than CABG in such a group of patient, even if this patient has high syntax score. Because on the other hand, this patient has a very high risk, surgical risk. And of note that the traditional risk scores like Euro2 score or STS PROM score underestimate the risk on this group of patients, because radiotherapy is not one of the parameters included in this score. And the patient faces a very difficult surgical field with extensive fibrosis around the heart, and as we said, the grafts we might use might be also affected. Another the thing that might be considered, TAVI rather than surgical valve replacement on patients with severe aortic stenosis caused by radiation, even if the patient have intermediate surgical risk. Because as we said, The surgical risk score usually underestimates the risk in radiotherapy patient. So if we have a patient with intermediate risk, this means that this patient at least has a high or very high operative risk. Another thing is if our patient have a cardiac device like ICD, CRT, or pacemaker, is it safe to receive radiotherapy or not? And how should we manage this issue? The first question is this patient is pacing independent or he have ICD and received frequent therapy? If the answer is yes, regardless of the dose and regardless while the device in the field of radiation or not, this patient is a high risk. The other question is the patient not pacing independent and not receiving frequent ICD therapy will be is the device on the field of radiation, then a dose more than 5 gray of neutron therapy is a high risk. And if not in the field of radiation, a higher threshold with a dose more than 10 gray is a high risk. So, what should we do with a patient with high risk of device interference? We might consider a multidisciplinary team discussion about moving the device into the other side, like if the patient receiving radiotherapy for left breast cancer, we might consider to move the device into the right side. But we should take in consideration also the potential risk of this fragile patient to develop device-related infection. So should be balanced. And we should also consider reducing the radiation energy and limiting the cumulative dose. During therapy, we should assess the device before therapy and weekly during therapy, and the patient should get monitored, at least with ECG during receiving radiation, with external pacing device or TC if the patient have an ICD in the nearby field. If the patient is only low risk, so we should assess the device at the baseline and audiovisual monitoring during the therapy, and again assessing the device after completing therapy. Finally, we reached the final stage, which is the long-term surveillance. At this stage, we should reassess the risk of patient again, because along this long journey, we have a new data about our patient. For example, our patient might be at a low risk at the start of therapy, but after finishing the therapy, we find that our patient took a very high dose of doxorubicin or a very high dose of radiation. So our patient become stratified into a very high risk category. On the other hand, if we have a patient with a very high risk at baseline, he's still at a very high risk on the long term. And another factor is has our patient developed cardiotoxicity during therapy, and what is the severity of cardiotoxicity that he developed? For example, if he developed moderate to severe cardiotoxicity during therapy, he is at a high risk. If he developed only mild, he is at a low risk. And the last question depends on the late risk, which is mainly related to radiotherapy dose. As we see here, we have a category called late high risk, which depends on the dose of radiation and the control of patient risk factors like diabetes, hypertension, and so on. So after we do risk stratification at the end of therapy, guide us during the surveillance, long-term surveillance. We divide it into short term during the first year after the end of therapy and long term after this 1 year. We should educate our patient about good and healthy lifestyle according to the preventive guideline, and educate the patient of the potential early warning symptoms of cardiotoxicity like chest pain, dyspnea, palpitation. And then we should do in high risk patient surveillance with biomarkers and echo at 3 months and 12 months post completion of cancer therapy. And this should be considered class 2A in moderate risk patient at 12 months. As we said before, this type of patient might develop cardiotoxicity like an anthracycline 98% during the first year with median at 3 months. Hence, the rationale for this cutoff points. Annual risk assessment of our patient with clinical examination, history about any new symptom, ECG, ProMP, and score risk assessment should be done for all patients. And if the patient continue to receive drug, he should be re-stratified at 5-year interval. So, what is the frequency of long-term follow-up with echo in these patients? If our patient is at a very high risk or a high risk early cardiotoxicity risk, he should underwent echo at 1 year, 3 year, and 5-year interval, then every 5 years. If our patient is considered at a high risk for late cardiotoxicity, this means this patient receives a high dose of radiotherapy. The surveillance starts at 5 years. As we said before, it usually start cardiotoxicity symptoms after 5 years of completion of radiotherapy. So the surveillance starts at 5 years and should be repeated with echocardiography every 5 years. Then this also might be considered with class 2B indication in moderate risk patient. Surveillance with echo every 5 years. If our patient at high risk for developing late cardiotoxicity, receiving more than 15 gray in the mean heart field of radiotherapy, then non-invasive screening of coronary artery disease every 5 to 10 years starting from 5 years after radiation has a class 2A indication. And if this radiation include the neck, cardiac ultrasound surveillance every 5 to 10 years after the 5 years should be considered. If the patient receives radiation on the abdominal or pelvic field and he has any signs of renal artery affection like worsening renal function or systemic hypertension, then renal ultrasound is a reasonable investigation. Finally, to summarize this long lecture, if we have a cancer patient who is candidate for a potentially cardiotoxic drug, we should undergo baseline risk assessment using the HFA-ICOS risk assessment tool, then stratify our patient to low, moderate, high, or very high risk. Then the surveillance during therapy will depend on this risk assessment with standard surveillance protocol for the low risk patient, cardiology involvement for high risk and very high risk patient, and might be considered to be in moderate risk patient with closer surveillance interval in moderate and very high risk patient. Then the third station after completion of therapy, early surveillance during the first year and at 3 months and first year interval in very high risk and high risk patient. Then long-term surveillance depending again on the risk assessment at the end of therapy. If our patient is at a high risk or a very high risk, then surveillance at 1, 3, 5 years intervals and every 5 years is reasonable, with annual cardiovascular risk factor assessment with the score risk and lifestyle modification. This take class 2B recommendation for every 5 years if you have a moderate risk patient. Again, with annual cardiovascular risk factor assessment and risk stratification at 5 years if the patient continue taking chemotherapy agents. And thank you.